Good evening. Thank you for joining us for the next install in our GOG accrual culture. We have a wonderful panel this evening, and we're going to be talking about diversity and inclusion in clinical trials. I'm going to ask our panelists to introduce themselves and where they're from.
Hi, everyone. I'm Dr. Amanda Briegel. I'm a GYN oncologist at Oregon Health and Science University in Portland, Oregon.
And I'm Colleen McCormick. I'm also in Portland, Oregon. I'm at the Legacy Cancer Institute as also a GYN oncologist in a hospital-based private practice.
And hello, I'm Dr. Tara Castellano. I'm a junior faculty member at the Louisiana State University Health Sciences Center in New Orleans, and I'm a practicing GYN oncologist there.
I want to thank all of you for being here. You all have demonstrated your commitment to women with gynecologic cancers through tremendous enrollment. And so I want to talk about how do we become successful, specifically as it applies to diversity and inclusion. We recognize that there are challenges to being able to actually achieve this for our patients. So actually, why don't we start there? Why don't we talk about what are the challenges and despite them that you all have managed to be successful? We can start with Dr. Briegel.
I think there are a number of challenges, which means there's a number of solutions. But I think one really significant challenge is the time and money we ask our patients for when they enroll in clinical trials. It's time off work, it's time to get labs, there's childcare, dependent care. And these are the unaccounted for costs that we ask them to pay for by enrolling. And it's a real privilege for our patients to be able to say yes and do that. And we're missing out by not allowing the people with privilege to be able to participate in things like this.
Absolutely. I think it's that ungraded toxicity of financial toxicity. Dr. McCormick?
Yeah, one of the challenges that we've had is the lack of consent language, consents in different languages. So often trials only have consents that are in English or maybe Spanish, but with diverse patient populations, if we don't have Russian document or Swahili, that can make it very difficult to enroll, either because of the time that it takes to get those documents translated, which then kind of, makes that time to enrollment much, much longer, or just the cost for a center, because a lot of times centers need to swallow those costs themselves. And for programs that are running, research on a relatively tight budget, those are just prohibitive in a lot of cases and lead to patients not just functionally not being able to get enrolled.
Right. I mean, that's almost a basic now, right? I think we have so many cultures, languages in our society now that just providing one seems sort of archaic at this point.
Yeah, absolutely. And you can get something translated relatively quickly, but then to get that through an approval process, get the stamp on it, takes adds significant time to enrollment.
Agreed. I share that struggle. Dr. Castellano?
I think one of the, on a larger scale, issues is really reconciling the culture of really having a community that understands the importance of clinical trial enrollment. Because if that's missing, then you won't ever understand the importance of having equitable clinical trial enrollment. And chronically under-resourced areas, not the coastal, large academic centers, but maybe, the smaller community centers, the smaller university sites that have more opportunity, but they don't have as much budget to really go and promote that in the community. So I feel just getting the word out, showing the importance of participating in clinical trials, and then really bolstering up those smaller underserved sites to really show their importance on enrolling in clinical trials and community outreach and everything that follows through that. Because the truth is, we need to dispel the myth that the patients don't want to participate. They do want to participate. We just need to understand how important it is and make it part of our everyday conversation with our, not just our patients, but our referral base and our PR for our hospitals and our academic sites. It should be what we're talking about all the time. And then what should follow is how we're improving that equitable enrollment and how that improves outcomes. And we want those improved outcomes for everyone.
Right. I recently read a paper talking about decentralizing clinical trials, right? So everything has to be done at the big house. You can't have a CAT scan in your small local, community. It won't be accepted by the trial. And I think, when we put those sort of burdens on patients, again, we're creating barriers that may not be necessary. I think, CT equipment is pretty standardized across health systems. Does it really have to be done at the hospital 90 miles away, or can it be done at their community? So thank you for raising a lot of those issues. Are there other things that we want to sort of talk about that we want people to recognize that, even though we are accruing, that we're struggling with these things as well?
I think just to your point, as far as getting things out in the community, one of the benefits that we've seen from COVID is how much, can be done virtually. Obviously can't do a virtual pelvic exam, but, many other check-in symptom visits, those kind of things. I think, if we can increase access to that, and utilize that more for clinical trials, we can, obviously you still need to come in to get your blood drawn. Again, something you can't do virtually, but a lot of the, kind of toxicity checks or stuff can be done virtually and decrease that burden.
Agreed. So I want to talk about how you've been able to overcome some of these challenges. I think they definitely are significant and universal, but you've been able to overcome them at your individual practices. So let's talk about your successes.
I'll go first. One of the things that's been really helpful for us is making things systematic and organized so that everybody gets screened, and it's not just dependent on the provider, the physician saying, oh, I remember I've got this trial going on, or, oh, I think this would be a good candidate. That making things systematic addresses a lot of different barriers, but one of the things it also addresses is it decreases kind of those intrinsic biases that physicians, we kind of all have an idea in our head as to who might be a perfect research candidate. And if you just screen everybody all the time, it just becomes part of what you do for each patient. And then a lot of those barriers fall away, and you find that these patients are, just like you said, very eager and willing and, want to be in those trials. And then, once you've presented it to them and they're interested, then you can work on fixing, social work issues if we need to, or rather than just saying, oh, this isn't going to be a good candidate. So making it systematic, so every single patient who has a new diagnosis, a recurrence or progression always gets screened, kind of makes things just more systematic and decreases that kind of internalized biases.
Absolutely agree. When we conduct our tumor boards, that's our language. What trials, the question gets asked, and what trials is this patient eligible for, and what will be discussed. And it also highlights where we have gaps. Are there things that we need to open because we now have this disease site becoming more common?
Yeah. I think you both bring up a good point, and if we sort of make it more macroscopic, systemic racism needs systemic solutions, and universal patient acknowledgement of, does this person meet the criteria for inclusion? Not, do I determine, does this patient make a good candidate? And I think we can look at all the touch points of enrollment of clinical trials at our institution, and we can start identifying the biases. One thing that we're doing at our institution is we are going to the IRB and asking for each IRB submitted at our cancer center, have you reached out to the community outreach and engagement team to determine how they can help you reach the community with this. And so that's just one example of another touch point that we can all think about. Little movements can potentially lead to big change down the road. And we all need big change if we're going to see these clinical trial enrollees change at all.
Yeah, I completely agree with everything that everyone else has said. And I think one thing coming from a little bit more of a hodgepodge of a healthcare system that I work in, when you don't have the clinical trial machinery in, or maybe your institution or practice is at the ground up building, I think it really serves you. So I can't say it's from my own merit, but I've been brought in very lucky to start the initiative to promote clinical trial enrollment and to bring in not just the providers, but the nurses, the nurse navigators, lay navigators that look like the population they're serving. So can really foster that environment. And, you know, when you start your clinical trials program through that disparities lens, and you want to serve the people and you hire people and they're excited about it. So when you do have a fully functioning machine, you really have a common mission, which is to offer excellent cancer care, clinical trial care for all patients equitably. So I think, you know, not all of us are starting, we're coming into a well-running machine, and we can find our role and really promote that message. But if you're working at a smaller site, you know, you can be the change, and that's really exciting when you have more opportunity to be that. So if that's something that you want to promote at your site, there's lots of funding opportunities, time to do that, community outreach, and all these resources. It's a big hot topic right now. So I'd say right now is time to strike and really improve this for our health systems, our patients, and our communities.
Absolutely. I think 12 years ago, my hospital used to enroll 3 patients a year. And, you know, when I said I came from a place where we enrolled thousands, you know, they kind of looked at me funny, and the sense of urgency that I put forth as, you know, this brand new fellow really shifted the culture, that it was, you know, unacceptable to not have clinical trials and have a cancer program where you care for women with gynecologic cancer. So I think, you know, it's about what is standard of care. And for us, when we care for women, it's being in a place where they have access to clinical trials. I do agree that we do have the ability as individuals to shape our small parts of the world and then be impactful. Because we also want our data to be important to everyone. We can't continue to produce trials where the data isn't applicable to the patient who's sitting across from us. I wanted to just thank you all for your time. Is there anything else that we should sort of highlight this evening for our listeners? I think the work that you're doing is tremendous. I would briefly want to touch on, we talked about community, but has anyone worked with patient advocacy groups? And maybe a way that we can begin to bridge that as a powerful tool in helping to empower our patients regarding clinical trials.
I think that's something that we're working on here. I think one way that we're doing that is we're really, like Dr. Briegel said, was really engaging the community through minimizing the amount that they have to come in and see us in person. So we engage the community through, you know, their providers, their primary care doctors. But I have seen a lot of successful sites that have really engaged community navigators, patient advocates really successfully, and it really bridges a gap that I really am hoping to open here. And I think that's a great path forward.
What we've found at our site is just going to a lot of health fairs. So we may not even be talking about cancer. It may just be talking about fibroids. And then we talk about, you know, but they could be cancer, right? We kind of slip that in, and, you know, how do we figure those things out? And I think just people seeing us, you know, outside of the cancer center is very powerful. I definitely have had patients that, oh, you spoke at my church community health fair, and how that was even more impressive than like anything else that had happened. And so I think, you know, when we embrace the community, we can't go to every health fair, but just having the opportunity at times to be where our patients are, I think was very eye-opening for myself as well.
I think when the community comes forward and asks for something, finding a way to say yes is incredibly powerful and important. I have a partnership with the Northwest Portland Area Indian Health Board, and essentially any ask that comes from them, the answer is yes. Do I want to talk about pap smears? Absolutely. Guidelines changed again. I am dying to talk to you about them. You know, I think really showing energy put forth into their ideas and their needs is the most powerful way to show that you and your team care.
And
Absolutely.
that you're listening. Yeah, absolutely.
Well, thank you everyone for your time this evening. Thank you for your dedication to our patients, and thank you for continuing to do this work. I think hopefully we'll have a GOG accrual that says these are all our successes. These are all the things that we've managed to overcome. And as we see papers coming out and we look at demographic charts and the numbers are shifting, I think we'll kind of see the fruits of our labor. Have a good evening, everyone.
Thank you.
Thank you.
too.